Good morning, students. Today's topic of discussion is oral anti-diabetic drugs. I will cover oral medications that are used in type 2 diabetes mellitus, and these drugs are also called oral hypoglycemic agents. But we need to know here that not all oral anti-diabetic drug cause hypoglycemia. Some drugs are euglycemic as well. Now we are coming to classification of oral anti-diabetic drugs. This picture is taken from K.D. Tripathi's textbook of pharmacology, and you can see some drugs like sulfonylureas and mesleutinide analogs. They can cause release of insulin and thereby decrease blood sugar. They can cause hypoglycemia. Dipeptidyl peptidase 4 inhibitor, or simply say DPP4 inhibitors, they indirectly release insulin and thereby control blood sugar level. But other drugs like biguanides and thiazolidine di-1, they have diverse mechanism of action and decreases insulin resistance. I'm coming to it later, what is insulin resistance. Acarbose mezlitol, these alphaglucosidase inhibitors, they inhibit carbohydrate absorption. They inhibit breakdown of complex carbohydrates and thereby decreases absorption of complex carbohydrates. New drugs are coming up like dapagliflozin, canagliflozin, empagliflozin. They are SGLT2 inhibitors. They decrease blood sugar in a novel mechanism. And some other drugs like dopamine D2 receptor agonist, exenatide, liraglutide as well. They are also used in type 2 diabetes mellitus. Now coming to sulfonylureas. Sulfonylureas bind with sulfonylurea receptor present in beta cell of pancreas, and they inhibit ATP dependent potassium channel complex, thereby causing depolarization that leads to cascade of events causing insulin secretion. As a result, there is decrease in blood sugar level in type 2 diabetes mellitus patient, but same can also happen in normal subjects because released insulin decreases blood sugar even in normal patients. Second generation sulfonylureas are more potent and clinically superior. Examples are glimepiride, glyclazide, and only tolbutamide belonging to first generation sulfonylurea group are used nowadays. You can understand from the discussion that sulfonylureas require beta cell function, requires presence of insulin in our body so that they can act. In the previous slide, we have seen that sulfonylurea causes insulin release. This is called insulinemic action of sulfonylurea. But after taking sulfonylurea for a few months, it has been seen that this insulinemic action is decreased. This is because there is downregulation of sulfonylurea receptor, but the blood sugar control stays adequate in spite of decreased insulinemic action of sulfonylurea. It has been proposed that due to adequate blood sugar control over a period of time, there is reversal of insulin resistance, and the insulin receptors which were downregulated comes back to the surface, and blood sugar level is controlled adequately by this lower level of insulin. Here I would like to say that type 2 diabetes mellitus is an insulin resistant state. By this I mean to say, though there is presence of adequate amount of insulin in the body in type 2 diabetes mellitus patient, it fails to control fasting or postprandial blood sugar adequately, and they require higher amount of insulin to control it. Sulfonylurea or exogenously administered insulin is required to treat type 2 diabetes mellitus patients. Sulfonylureas are administered orally and they are absorbed well by oral route, and 90% or more bound to plasma protein. So you can understand the volume of distribution will be less. It is 0.2 to 0.4 liter per kg, and they are metabolized into active metabolite in liver and excreted in urine. So we need to administer sulfonylureas cautiously in liver or kidney patients. As sulfonylurea can cause hypoglycemia and it can be life-threatening, we need to understand drug interactions of sulfonylurea. Those drugs which displace sulfonylurea from protein binding sites like salicylate sulfonamides can actually increase free drug and thereby it can cause hypoglycemia. Drugs like cimetidine, ketoconazole, which inhibits sulfonylurea metabolism, actually increases duration of action of sulfonylurea, so it can cause hypoglycemia, and we need to decrease the dose of sulfonylurea in those patients. It has been seen that lithium theophylline alcohol has synergistic action with sulfonylurea, and it can cause hypoglycemia. Again, some drugs can decrease action of sulfonylurea, and here we need to increase the dose of sulfonylurea. Examples are phenytoin, phenobarbital, rifampicin. They induce metabolism of sulfonylurea, thereby decrease duration of action. Some drugs like corticosteroid, thiazide, furosemide, and oral contraceptive, they increases insulin resistant state. These drugs should be avoided in type 2 diabetes mellitus patient, or we need to increase the dose of sulfonylurea in these patients. Now coming to adverse effects of sulfonylurea, we already know that sulfonylurea has insulinemic action, so it can cause hypoglycemia even in normal person. It can cause weight gain. 1 to 3 kg weight gain is seen in patients who are taking sulfonylurea regularly, and its safety is not established in pregnancy, so we need to change over to insulin in pregnant patients, and it is also secreted in milk, so not given in nursing mothers. Hypersensitivity is also another problem. Now coming to next group of drug, mesleutinide analogs. Examples are repaglinide, nataglinide. They also act by binding to mesleutinide analog receptors and inhibits or blocks ATP dependent potassium channels. These receptors are situated close to sulfonylurea receptor, and they has quick and short lasting insulinemic action. That means they also act by releasing insulin, and they are designed to normalize postprandial rise of blood sugar. They are quickly absorbed and rapidly metabolized, and they are very helpful in controlling postprandial blood sugar level, and they should be avoided if a meal is skipped. They can cause hypoglycemia, but chances are low compared to sulfonylurea as duration of action is smaller, but they can cause weight gain similar to sulfonylureas. As they are metabolized in liver, they should be avoided in liver disease. Today's class is related to oral hypoglycemic agents or oral medications that can be used in type 2 diabetes mellitus, but here I would like to discuss GLP-1 receptor agonist. They are given subcutaneously. Here I am discussing it so that we can understand DPP-4 inhibitors better, discussed in the next slide. Now coming to what are incretins. Incretins are GI hormone, and when we take food orally, incretins are released and it stimulates insulin secretion. It has been seen that if we administer GLP-1 receptor agonist at a supraphysiological amount by intravenous route, it causes insulin secretion, it inhibits glucagon release, delays gastric emptying, and reduces food intake. As a result, fasting and postprandial insulin secretion is controlled in a better way, and fasting and postprandial blood sugar level also stays within normal limit. But they are rapidly inactivated by the enzyme DPP-4, dipeptidyl peptidase 4, and they have T-half of only 1 to 2 minutes. Examples are exenatide, liraglutide, alphaglucosidase. Alphaglucosidase is the longest acting. It has T-half of 5 to 7 days and can be dosed once weekly. They are very good agent in reducing HbA1c level. Up to 1% reduction can be seen, and they also help in reducing body weight. Up to 4 kg of body weight reduction can be seen in type 2 diabetes mellitus patients. In the previous slide, we have seen that endogenously secreted glucagon-like peptide 1 is destroyed by dipeptidyl peptidase 4 enzyme. So if we can have any medication that inhibits DPP-4 enzyme, it will increase meal-related insulin release in our body indirectly. So DPP-4 inhibitors are indirectly acting insulin secretagogues, and they have moderate blood sugar lowering efficacy. Examples are sitagliptin, vildagliptin, linagliptin. They boost postprandial insulin release, decrease glucagon secretion, and lowers mealtime as well as fasting blood glucose in type 2 diabetics. They have low risk of hypoglycemia because GLP-1 evokes little insulin release at normal plasma glucose level. They are body weight neutral, whereas we have seen that GLP-1 receptor agonist reduces body weight up to 4 kg in diabetic patients. Examples of DPP-4 inhibitors are sitagliptin, vildagliptin, saxagliptin. Some cases of pancreatitis has been reported with sitagliptin, but it is rare. Vildagliptin, though it has shorter plasma T-half, 2 to 4 hours, but duration of action is actually longer, 12 to 24 hours, because it binds with DPP-4 enzyme in a covalent fashion. Linagliptin can be administered in renal compromised patient, and teneligliptin is a cheaper alternative, though some cases of QT prolongation has been reported with teneligliptin. Next group of drug is biguanide, which is adenosine monophosphate kinase activator. Only medication of this group available in market is metformin. Fenformin has been withdrawn due to increased incidence of lactic acidosis. It is euglycemic in nature, that means it has negligible chance of hypoglycemia. It improves lipid profile as well. Like the other drugs, it also requires presence of insulin for the final action. It activates adenosine monophosphate kinase and thereby it suppresses hepatic gluconeogenesis in between meals. It also helps in insulin dependent glucose uptake in skeletal muscles. It means metformin reduces insulin resistance. This taken up glucose in skeletal muscle is stored as glycogen. It also helps in reduction of lipogenesis in adipose tissue and enhanced fatty acid oxidation. It leads to improved lipid profile. It also helps in peripheral utilization of glucose by increasing anaerobic glycolysis. So metformin has diverse mechanism of action. All of them leads to better glucose management in our body and reduced blood glucose level. Metformin is usually consumed along with milk, and it helps in retarding intestinal absorption of glucose, other hexoses and amino acid. It can cause vitamin B12 deficiency, so patients who are taking metformin might sometimes require vitamin B12 supplementation. Little metformin is metabolized in our body. It is usually excreted unchanged in urine, so chances of lactic acidosis is there in renal failure patients. Usual side effects are abdominal pain, anorexia, bloating, nausea and metallic taste, and patient usually overcome these problems after a few months. Alcohol ingestion can precipitate lactic acidosis. It should be avoided in hypotensive states, heart failure, severe respiratory and hepatic disease. When a patient is first diagnosed with impaired glucose tolerance or type 2 diabetes mellitus, metformin is usually the first drug that is prescribed because it is euglycemic in nature, so chances of hypoglycemia is rare. It also helps in reducing weight because we know in type 2 diabetes mellitus weight gain is a problem. If metformin is taken for the long duration, it helps in preventing macrovascular as well as microvascular complications. Macrovascular complications like cardiovascular events, stroke, microvascular complications like nephropathy, neuropathy, retinopathy. As metformin improves insulin resistant state, there is little acceleration of beta cell exhaustion in type 2 diabetes. It can be combined with any other oral or injectable anti-diabetic drug. Other uses of metformin, it is used in polycystic ovarian syndrome. In PCOS, there is infertility due to decreased ovulation, and there is also weight gain. Metformin improves microenvironment of ovary, thereby leading to improved ovulation and increased chances of pregnancy. Next group of drug is thiazolidine type 1. It acts on PPAR gamma receptor as an agonist, peroxisome proliferator activated receptor gamma. It is expressed mainly in fat cells and also in muscles. Only thiazolidine type 1 that is available in market is pioglitazone. Rosiglitazone has been withdrawn due to increased risk of myocardial infarction, congestive heart failure, stroke and death. Some cases of urinary bladder cancer has been reported with pioglitazone. it is not used as first-line drug in type 2 diabetes mellitus. Pioglitazone helps in transcription of several insulin responsive genes, thereby it reduces insulin resistance. So there is better utilization of glucose, peripheral uptake of glucose in skeletal muscle and fat tissue is improved by GLUT4. It also helps in reducing hepatic gluconeogenesis. Lipolysis and plasma fatty acid level are reduced by thiazolidine di-1. It also acts on PPAR alpha receptor, leading to improved HDL level, decreased triglyceride level without much change in LDL level. Major side effect of pioglitazone is plasma volume expansion leading to edema. It can precipitate or worsen congestive heart failure, can cause weight gain. It also causes mild anemia, myalgia. It can improve fatty liver condition, but monitoring of liver function is advised in patients taking pioglitazone. We need to be cautious while using pioglitazone along with other drugs because there are several drug interaction. Pioglitazone is metabolized by CYP2C8 and CYP3A4 enzyme in our liver. Ketoconazole or other drugs that inhibit these enzymes actually enhance action of pioglitazone. On the other hand, rifampicin or other drugs that induce metabolism actually decrease action of pioglitazone. So there is alteration in blood glucose level if these drugs are taken together. Failure of contraception has been reported when OCP is taken along with pioglitazone. It is not prudent to use insulin along with glitazones because there is increased chance of fluid retention, weight gain and precipitation of congestive heart failure. If HbA1c level reduction is less than 0.5% even after 6 months of use, pioglitazone should be stopped and it is not used in pregnancy. Now coming to alpha-glucosidase inhibitors. Examples are acarbose, meglitol, voglibose. They are mild anti-hyperglycemic agents. Now alpha-glucosidase inhibitors act on alpha-glucosidase enzyme. This enzyme is present in brass border of our small intestine. This enzyme helps in digestion and absorption of polysaccharides and sucrose. So alpha glucosidase inhibitors, when they bind reversibly with the enzyme, it actually slows down and decreases absorption of complex carbohydrate, thereby reducing post-meal blood sugar level. It also helps in releasing GLP-1, glucagon-like peptide 1, which is released when we consume meal. Stop NIDDM trial in 2002 has shown that long-term acarbose treatment in pre-diabetics reduces occurrence of type 2 diabetes mellitus as well as hypertension and cardiac disease. In case of diabetics, it reduces cardiovascular events. Main problem associated with alpha-glucosidase inhibitors is flatulence, abdominal discomfort and loose stool. It is seen in up to 50% of the patients. Because there is unabsorbed complex carbohydrates in our food pipe, they undergo fermentation leading to these problems. In some cases, rise of hepatic transaminase is also reported. Next group of drug is sodium glucose transporter 2 inhibitors or SGLT2 inhibitors. SGLT2 is situated in proximal portion of renal tubule. We all know that glucose is freely filtered through Bowman's capsule and 80 to 90% of this filtered glucose is reabsorbed in the proximal portion of renal tubule by SGLT2. So SGLT2 inhibitors actually act by a novel mechanism. Their action doesn't depend on presence of insulin, nor do they affect metabolism of carbohydrates. When in diabetes mellitus patient blood glucose level rises above 180 mg per dl, there is loss of blood glucose in urine. SGLT2 inhibitors decreases this threshold level to 50 mg per dl. So blood glucose is lost in urine. As there is loss of energy in urine, there is loss in body weight in the range of 2 to 4 kg. This blood glucose also takes some water along with it, so there is loss in blood pressure as well by 2 to 4 millimeter of mercury. From the mechanism of action discussed in the previous slide, it is clear that SGLT2 inhibitors has to cross Bowman's capsule and has to reach proximal part of the renal tubule to act on sodium glucose transporters. So some amount of kidney function is required for this drug to act. As there is increased amount of glucose in urine, there can be increased chances of lower urinary tract infection in the range of 1 to 2%. Genital mycotic infection reported 3 to 5% more compared to normal individuals who are not consuming these drugs. Glucose comes in urine and it takes along some water, causes mild diuresis. So these drugs can cause hypotension in persons who are taking other blood pressure lowering agents. FDA has warned about increased risk of fracture. Canagliflozin has been associated with increased risk of lower extremity amputation. But the good point is that empagliflozin, canagliflozin or dapagliflozin has been seen to reduce major cardiovascular events. They prevent heart failure or improve these conditions. Among other medications that can be administered in type 2 diabetes mellitus patient, cholecyvalum and bromocriptine is there. Cholecyvalum is bile acid sequestrant. It reduces blood cholesterol level, but the mechanism by which blood sugar is also reduced is not known. Bromocriptine acts as an agonist in D2 receptor. It resets circadian rhythm of hormone release and thereby reduces insulin resistance. Previously, I have discussed about GLP-1 receptor agonist. These drugs are administered subcutaneously. Now again, I am going to discuss another drug, brambleindict, which is also administered subcutaneously in type 2 diabetes mellitus patient. Amylin is produced from pancreatic beta cells along with insulin. It acts on hindbrain, thereby reducing glucagon secretion, delaying gastric emptying, and it also produces a feeling of satiety. So as a result, blood glucose level is controlled. It can also be administered in type 1 diabetes mellitus patients. Now it is being evaluated as a drug for weight loss even in non-diabetic person. Synthetic amylin is pramlintide. Now this is a busy slide. In this slide, all the medications that I have discussed so far has been summarized. On the left hand side, you can see the name of the groups. First example is biguanide. Metformin is the only available biguanide. It acts by decreasing hepatic glucose production. It also helps in reduction of insulin resistance. Main side effect is lactic acidosis. Metformin usually the first drug that is prescribed in type 2 diabetes mellitus patient, but European guideline is saying that if the patient is also suffering from cardiac problem like heart failure, SGLT2 inhibitors like dapagliflozin, empagliflozin can be chosen as the first drug. SGLT2 inhibitors act by increasing renal excretion of glucose. DPP4 inhibitors are indirectly acting insulin secretagogues. They act by prolonging endogenous GLP-1 action. Chances of hypoglycemia is less compared to directly acting insulin secretagogues like sulfonylureas and meglitinide analogs. Alphaglucosidase inhibitors act by decreasing absorption of complex carbohydrates, and thiazolidine diazones, they act by decreasing insulin resistance as well as improving peripheral utilization of glucose, but congestive heart failure is a potential problem. In this slide, a general outline has been depicted about how type 2 diabetes mellitus patients are treated with oral agents or insulin. When a patient comes with impaired blood glucose or type 2 diabetes mellitus, we assess them by measuring fasting and postprandial blood sugar as well as HbA1c, and if the measurements are on the higher side, we need to educate the patients about proper nutrition, physical activity. Metformin is usually the first drug that is prescribed. Now, one thing we need to keep in our mind that when a patient develops impaired blood glucose or type 2 diabetes mellitus, they usually do not seek doctor's advice in the beginning because they usually do not have any problem in their lifestyle. They usually comes after 4 to 5 years, and by that time some microvascular as well as microvascular complication might have developed, so we need to look for them as well, like retinal examination, whether the person is suffering from microalbuminuria, there is neuropathy or not. We also look for other comorbidities like dyslipidemia, hypertension, obesity, and we need to take care of those factors as well. Now, after a few days, we need to reassess HbA1c level. HbA1c usually tested at least after 90 days. If it is not controlled adequately, a second agent is added along with metformin, and we need to reassess again after 90 days. HbA1c is measured after 90 days because average lifespan of RBC is 90 days. If it is not controlled adequately, then we need to add another agent. So here the patient is getting metformin plus two other agents. The second agent can be sulfonylurea. If the patient can afford, they can have SGLT2 inhibitors or DPP4 inhibitors. If required, in this situation, patient can also be advised insulin. Then we need to reassess HbA1c again and titrate the doses so that we can achieve adequate blood glucose level. So thank you for your patient hearing. Stay safe.